Hey, TJ.
Good morning and good afternoon, and thank you guys for attending. I just want to let everybody know that we'll start in just maybe a minute or so. I just want to give a little bit more time for everyone who's not logged in yet. So again, just give us another minute and we'll get started. Good afternoon. Thank you guys for joining us. My name is Delane Henry. I'm the CEO of Advanced Hospice Management. And today we'll talk about a few Medicare updates, CMS updates, and an OIG report. So I just wanted to tell you guys a little bit about our company for those joining us for the first time. We are a hospice-only, third-party, independent billing solution. We're geographically dispersed. We have billers all over the country, and we also have clients throughout the country and Puerto Rico. We have redundancies in place. Even though all of our clients are assigned a primary biller, we have backup billers and layers of protection so that billing is never interrupted for any reason. Obviously our billers go on vacation and things like everyone else's, but because we have a team of professional billers, there's always someone to manage your claims. We have a 24/7 hotline. Our billers work collaboratively to stay up to date with all regs and guidance and any changes and updates for billing and anything that pertains to hospice billing particularly. We pride ourselves in the best customer service, and we, again, keep our billers educated on the most recent changes, and that allows them to maximize collections for our clients. If you guys have any questions regarding our services, please don't hesitate to contact me directly through email or on our website. I'll be happy to answer any questions that I can for you. So today's presentation will cover a few things. CMS has released the new hospice PUF reports, which are public use file reports, which basically is a whole list of metrics for hospices that will include utilization, payments, charges, diagnosis, and beneficiary demographics. And that's all included and organized by provider and state. So that's a really interesting website. If you guys haven't visited, I would certainly recommend that you go there. It gives you quite a lot of information, not only about your particular hospice, but other hospices in your general area, specific area, state, and nationally. We'll also talk about the ICD10 updates. This was our first coding update since ICD10 has been implemented, and I don't know how much you guys are trained or are training or continuing education on coding, but all of the guidelines pertain to hospice, so it's really important that we stay up on those guidelines. And finally, in October, OIG released a study and recommendations about hospice election statements and certifications of terminal illnesses. So that's important as well. Obviously, they're finding that some of our election statements aren't sufficient, and some of the CPIs don't give enough information to qualify that patient for hospice services. So we definitely want to read that report in depth and look at what the OIG is recommending. So again, the first thing we'll talk about is the hospice Utilization and Public Use file that was released on October 6th. And this is really great because, again, it gives you all of this information based on demographics for beneficiaries and individual hospitals. So they're looking at cost per beneficiary, days of service, percentage of beneficiaries with certain diagnosis, percentage of beneficiaries with live discharges. And we know that this is all information that Medicare has been gathering for their own use for things like targeting audits and payment even, and looking at diagnosis and lengths of stay. And so these are all really important data bits for all of us, because we know Medicare is looking at those, and we should be looking at them as well to see where we fit. You know, are we above the national average or below or right at? You know, these are things we can measure our hospice and our performance in relation to other hospices. Here's just some of the results. This is the total results from this report. Tells you how many beneficiaries. Now, granted, this is from 2014, so we don't have more recent data, but we will get that data, and I'm really hoping that they don't stay 2 years behind. It would be really great to have this in a more timely manner. But this gives us the number of hospice beneficiaries that were served in the year 2014 for Medicare. It tells you how much money Medicare paid out, and as you can see, $15.1 billion of payments gives us an idea of why they're looking more closely at hospice and trying to make our services more transparent to prevent fraud and abuse. How many hospice care days we've cared for patients, how many live discharges. This is interesting. I find that the hospice beneficiaries with 7 or fewer hospice care days at 354,000 patients. I think that's really probably a case of maybe us taking hospice patients too late instead of too early. I know we always want to focus on patients like beneficiaries with more than 180 care days, but there's 169,000 of those with 180 or more, but there's 354,000 with 7 days or less. So it appears that there is room for hospice-appropriate patients to come into hospice care a little bit sooner on that number. And then, of course, you always want to look at those patients that are in your service more than 180 days and really determine if they still meet criteria, if they're declining, and make sure that we're monitoring those patients closely. Another interesting fact here is our hospice beneficiaries with the primary diagnosis of cancer is only 29% of the beneficiaries, and we all know that we are seeing other segments of diagnosis, patients with other diagnoses that are growing, and Alzheimer's and other types of dementias are definitely in there. We're seeing a lot more heart disease, a lot more respiratory disease, and strokes. So cancer is not a primary diagnosis. That is the majority of beneficiaries by any means. The other release that Palmetto did, or I'm sorry, that CMS did, was the market saturation and utilization data. And this is an interactive map. And again, I apologize that I don't have the link, but this gives us an actual map of the country, and it shows us all of this data based on your location, your state, and you can click on the state and get lots of different data points and information about the agencies in your particular area. And I agree that hospice is one of those areas that I don't think has had a lot of transparency, and Medicare, by releasing this information, is giving us more transparency to prevent fraud and waste and abuse, because part of the utilization data shows us, how saturated our market is in our particular area, and that allows providers to, make better decisions about servicing their locations and the beneficiary population. Because I'm sure if we really did some heavy research into these numbers, we may find that there are some areas that just have way more hospices or way more healthcare providers in general for a particular type of service, and other areas that are underserved. So this will help CMS and providers determine what areas there are in our country that are in need of our services. The next release, and I'm not sure how many coders we have on the call, but the ICD10 update, we had our first update on October 1 of this year, since ICD10 was implemented October 1st of 2015. And it's the first coding update we've had since 2012 because with the anticipation of ICD10, the ICD9 codes were frozen, so we didn't really have any real updates on the last couple of years that we were using ICD9. So ICD10 changes were quite a few, obviously, because we had not had changes at all, and this is the first change and first update in ICD10. So they've expanded some codes, they've deleted some codes, and granted, we have a tremendous number of codes in ICD10, so some of us in hospice maybe aren't even seeing or noticing the changes because I know a lot of these code changes had to do with other segments like fractures and things that we may not see a lot of in hospice. But they've given us some new guidance along with the code changes. They've clarified some of the things like, you know, now they're defining with in our guidelines. So when a code, specifically something like diabetes, when you read in the code book and it says diabetes with, and there's a list of manifestation codes caused by diabetes, we can now say that we can assume that those codes are related, and that is not something we could do in the past. So there are some guidelines that are really important because, again, hospice is required to follow the ICD-10 guidance. We have to code following the rules, just like every other type of provider. And I think that may be newer to hospice than most providers. So it's really important that we do a continuing education for ICD-10 in our agencies, and that we make sure that we are following the rules. And here I went out and I asked, as a coder, I have a community of coders that we work together. We bounce questions off of each other, particularly when we have complex cases. And so I asked 1,300 coders, what they thought were the most challenging hospice coding issues. And these were the top 3 answers. So the first is that it's lack of education or experience in coding in particular in the agency. And so there are a lot of people that are still relying on Google or a phone app to use for finding an actual ICD-10 code based on what you might type in as a description of that code. And the problem with that is finding codes in general is kind of a skill in itself. So typing in a description may not bring you to the actual code that you want to use or need to use or is accurate for your patient. But it also doesn't give you any tips or rules or regulatory guidance. So just choosing a code without knowing if you're using it in the right context can be an issue in itself. And so, it's compounded by the fact that ICD-10 now is a brand new code set for us. We've only been using it for a year. And so it's not like in ICD-9, I think nurses in particular became familiar with codes that we used often. And now that whole new data set is not as familiar, obviously. So I think education is key here, that we really need to get more educated on ICD-10 guidance and rules and make sure that we're following those. The second challenge that coders see in hospice is that many agencies are still coding only 1 or 2 maybe diagnoses and not following the CMS guidance that requires hospice agencies to code on the claim all coexisting or additional diagnoses that are related to the terminal illness and other related conditions, and also any comorbid or unresolved conditions that exist at the time of hospice care. So basically, we were instructed to code all terminal illnesses and related conditions and non-related conditions. So you should rarely see, I would think, in the demographic of the average hospice patient, that you're going to find a patient with only 1 or 2 diagnoses. So we really need to make sure that we're following not just the coding guidelines, but CMS's direction that we have to code all of the diagnosis that is present with the patient that could impact the plan of care. The third ICD-10 challenge is that physician documentation, of course, isn't always as strong as we need it to be in order to document a particular diagnosis on a patient. So if a patient has hypertensive kidney disease and the primary or the terminal condition is truly the kidney failure, the physician will write kidney failure on the CTI or the patient's paperwork every time. But for coding sequencing, we may have to code that as a manifestation code and not as the primary diagnosis. So we still do have to follow the coding rules, and I think that again may be part of an educational opportunity for our physicians, that we maybe need to present these things and have them understand a little bit better how we have to code and how we have to follow these rules, and I think it's just a matter of letting them know how we have to sequence. And the last thing we'll cover today is the OIG study. This is really important, and I think it's something that we'll see probably a lot more about once, if Medicare, and I'm assuming CMS will take the recommendation of the OIG, because what this study did was it tested the legitimacy of statements of election and certifications of terminal illness. And it was conducted because the OIG believed that both the statements of elections and certifications were misleading, and they believed the physicians were far less involved in cases, and that the OIG took random samples of elections from GIPs from 2012, and this is what they found. They found that more than 1/3 of election statements lacked required information. It often did not mention that beneficiaries were waiving their right to curative care, and 14% of GIP states physicians did not meet the requirements that had limited involvement in determining if the beneficiary was appropriate for hospice care. And as a result, they provided 4 recommendations to CMS to solve this issue. First, they want to develop and disseminate a model text for election statements. And Medicare has not, they've been resistant to do this. They have not issued a formal or a sample of an election statement. And OIG is really saying to them that they really need to do this to make sure that all the data elements are present. They want to instruct surveyors to strengthen their review of election statements and certifications of terminal illness. They want more education for hospices about election statements and CTIs. They want to provide guidance to hospices regarding the effective beneficiaries when they revoke their election and when they are discharged from hospice care. That one in itself, I think, doesn't get a lot of attention from hospices, and I'm not saying everybody, but I think there are some deficiencies in how a live discharge in particular, is handled, specifically when it affects a patient that maybe has a Part D drug plan and the patient is a live discharge. There are some repercussions for the patient on that, so it's really important that we have a process in place to make sure our patients are taken care of once they leave our service. So to receive hospice services under the Medicare benefit, the patient or his authorized representative must elect hospice care by signing the election statement. And this is what OIG is saying, even though right now the hospices design and print their own election statements, the OIG would like CMS to present or create a form that makes sure all the data elements are present that agencies can use to model their own election statement off of. So this is a list of everything that the hospice election must include. It must identify the hospice, obviously, that will provide care for the patient. The patient or the patient's representative must acknowledge that the patient has been given a full understanding of hospice care, particularly the palliative care rather than curative nature of treatment. The patient or representative's acknowledgement that the patient understands that certain Medicare services are waived by the election. The effective date of the election, which can be the first day of hospice care or a later date, but cannot be a retroactive date, and the signature of the patient or their representative. Now, in 2014, they also stated that it must include the patient or representative designated attending physician, and if they have one, and it needs to include enough detail to clearly identify the attending physician by including his full name, office address, MPI, and the patient or representative's acknowledgement that the designated attending physician was their choice. And that's important. Again, that's a patient choice. So those are the issues that, that OIG identifies. This is just some more information about the if a patient changes their attending physician, that they must file a signed statement with the hospice, and the statement must include this following information, basically the same information identifying the new attending physician, and the date that the change is effective, acknowledging it was their choice, signing it, and dating it the day it was signed. Any hospice election statement or statements changing the designating attending physician that is missing any one of the bulleted items above is considered incomplete and may result in the claim being denied. So it's really important that, of course, you have that attending physician on your initial CTI and that you document correctly if your patient changes attending physicians during the course of their care. I think it's really interesting that the OIG has come back with these recommendations to CMS, and obviously for all hospices, I think it would be on the top of my list of importance to make sure that all of your forms meet these criteria. Obviously, if OIG is finding errors or omissions on the forms in a random sample test, that you can be sure that they will be looking harder at these items on any type of audit, ADRs, ZPICs, even state surveys, because obviously they found an area of weakness and they really want to make sure that we are all compliant. And CTI is extremely important because it is a patient election. So that's really all that I have for today. I'm going to give you guys a minute, and I think I may have a few questions that I want to go over here. And then if you guys have any additional questions, take this time, please, to type them out. So I'll be going through those. Give me a minute, and I'll come back and answer the ones that I can. And if you guys have questions that you don't get on to this questionnaire while we're on the webinar, please feel free to email them to me. But let me look at what we have now and see what I can answer. Okay, I apologize. The only question that I can see, and my box is really small here on this webinar, so I did scroll through, and the only question I'm seeing right now is regarding the discharges or the hospice patients that have 7 days or less of hospice care, and that was back on our HUF report. And let's see if I can go back to that page. This page. So the question is, with the patients that have fewer than 7 hospice care days, are they dying within the 7 days? Well, I believe from this report that they are including all hospice beneficiaries who had any hospice care during that year, and that would include deaths and discharges. So if you have a patient who only had 2 or 3 or 4 days, whatever, of hospice care and revoked or was determined to not meet hospice criteria and was discharged, those patients would also be in that figure. So, you know, again, it may not be that all of these patients should have started hospice care earlier. Some of them may have determined that they didn't want hospice care or didn't meet criteria, or for whatever reason decided to terminate their hospice election. So that may not necessarily be all dying patients, but I do have to think that with 354,000 of them, I would think a significant number of those patients probably passed away in those 7 days. And doing the billing that we do for companies across the country, we do have quite a few claims for short stay hospices where the patient expires. So I would think the majority of those are patient deaths. That would be my opinion. Again, I can look into those numbers further, and when you get onto the CMS site, you may actually be able to go further into this data and look specifically if they break it down by discharge type. Was it a death? Was it a revocation? Was it a discharge? You know, those things may be available in that report. So again, guys, that's the only question I can find when I scroll through. But if I missed your question, or if you have a question that you want emailed to me directly, please feel free to do so. I'm going to go back through these slides. I believe we have a contact slide at the bottom. Yes. So again, my name is Delane. You can reach me at dh@hospicemgmt.com. You can call us if you would rather call. That would be fine. But I'll be happy to answer any questions I can. And if you guys have an opportunity to review the reports on the CMS website and have further questions or would like more information, please feel free to contact me at any time, and I'll be happy to help any way I can. So thank you guys for joining, and I hope to see you again next month. Be on the lookout for our next newsletter, and then we'll schedule our webinar shortly after. Thank you guys. I appreciate it. Have a great afternoon.